antigen antibodies, these are not by, you can't judge that you had a T cell immunity,
And that will deplete in over time.
The T cell immunity
will
would
deplete.
only stay, isn't it?
Yeah.
And how do you assess that?
T cell immunity assessment is very difficult, sir. How to assess? I have no idea. It is very difficult.
Sir, all the panelists have joined already.
So, Mr. Chinmay, you can start with your introduction.
Right. Anindo sir, welcome. Good evening. Supradeep sir and Anindo sir, if you can switch on your video kindly.
I would request all the panelists to switch on their videos at least for the time being. Yeah. Thank you, Dr. Supradeep.
Sir, namaskar. Good evening.
Good evening.
Sir, kindly unmute yourself, sir.
Dr. Anindo, can you switch on your video and audio?
Yeah, live on audience link.
Okay, now it is fine. Can you hear me?
Anindo sir, we can hear you, but your video is still off.
No, Supradeep, we can hear and see you both. No problem.
Okay.
Right.
Anindo sir.
Aninda and who else? Two doctors are not on.
Tapabrata sir has logged out.
Why?
Let me talk to him, sir.
I hope he doesn't have an emergency or something. See, Tapabrata was asking a question about COVID and primary, isn't it, Dr. Ritin? You also heard that question, isn't it?
Yes, sir.
Yes, sir. I'll tell you a story. This patient got admitted under me on 19th April. Okay, and he came with an interval MI, and he had a blood pressure which was on the higher side, 160/100, but he was in frank failure that he could not lie down, and we put him on NIV and managed him with the failure. And at the same time, because I was the only operator, so I was slightly scared, so I gave him, because he came in 3 hours of pain, so I gave him TNK TPA. The others has joined. Chinmay, you are starting?
Yes. Tapabrata sir is back.
Yeah, he's back.
Sir,
I'll tell you, this is very interesting story.
So I will take a couple of minutes. Omkarji is there. He is coordinating from Mumbai.
Okay.
He'll just share the flow of the meeting. Omkarji, if you can kindly.
Yes, sir. Good evening, sir.
Good evening, Mr. Omkar.
How are you, sir?
I'm good. Thank you.
Great, sir. So this is our debate webinar called as Antithrombotic Updates, where we'll be having discussion on 2 case studies.
Right.
So the first case study will be presented by Dr. Sunil Lila, sir. And sir will be throwing some questions to the respective panelist, which the other panelist can give the comment upon how to manage a particular case. So after the first case, we'll move to the second case of atrial fibrillation. There also case study will be presented by Dr. Sunil Lila, sir. And there also he will be asking the questions to the respective panelists, so which they can discuss or comment upon with their clinical experience. And after that, we'll be having question answer session from the audience. And overall, 45 minutes will be lasting the panel discussion, and then we can move for the vote of thanks, sir. This is all about, sir. Over to you, sir. Chinmay, sir.
Sir, with your permission, can we start? Leela sir, kindly unmute, sir.
So, Chinmay, let's start.
Yes, sir.
Let's not waste time in too much of introduction. Just give a small introduction and we can start.
So good evening all. On behalf of Alchem Lab, India's 5th largest pharma company, I welcome our respected moderator, sir, and all eminent panelists of today's antithrombotic debate, and all the doctors who have joined us for today's antithrombotic debate in this evening. As you know, at Alchem, we are always, it is our endeavor to partner with the healthcare professionals and medical fraternities. And in this difficult time also, we continue to do so. To help us to navigate through the session, we're extremely fortunate today to have renowned cardiologist, Senior Interventional Cardiologist Dr. Sunil Lila sir with us. Sir will moderate today's debate. I take this opportunity to welcome Sunil Lila sir at first.
Thank you.
And let me welcome you, sir.
Thank
I'll
you.
take this
Thank you,
opportunity
Chairman.
to introduce you, sir. Dr. Sunil Lila sir is currently working as a senior consultant interventional cardiologist and at Rabindranath Tagore International Institute of Cardiac Sciences. Sir is the chief of cardiac services at Narayana Multi-Speciality Hospital in Barasat. Sir has been the chief of cardiac services in Rotary Narayana as well, and has been chief of cardiac services in Narayana Hospital, MMI, Raipur, Chhattisgarh. Sir, incidentally, sir has performed more than 5,000 PTCA, 1,000 permanent pacemaker, more than 5,000 temporary pacemaker, and more than 700 valvoplasties. With this brief introduction, sir, I feel happy to welcome you in this debate. Welcome, sir.
Thank you.
I take this opportunity to welcome Dr. Supradeep Kundu, sir, who is working as a consultant interventional cardiologist in AMRI Dhakuria Hospital. Sir has completed his DM cardiology from Medical College Hospital in 2017. Post DM, sir is practicing as a consultant cardiologist for last 5 years. I take this opportunity to introduce Dr. Tapabruto De. Sir is a consultant interventional cardiologist at Charnak Hospital currently. Sir is practicing as a consultant interventional cardiologist and completed his DM from Arjikor Medical College Hospital. Welcome, sir. Tapabruto sir, very welcome in this debate. I welcome Dr. R.N. Tolapatro sir also in this debate. Sir is DNB General Medicine, DNB Card, MRCP, FRCP, and currently sir is Assistant Professor in Gauri Devi Hospital, Durgapur. Sir is also associated with Narayana Hospital, Barasat, and Teresa Memorial Hospital as a consultant interventional cardiologist. Welcome, Tolapatro sir. And I take this opportunity to welcome Dr. Anindo Sarkar sir. Sir is a consultant interventional cardiologist in AMRI Salt Lake, and sir is practicing as a consultant intervention cardiologist in various parts of Calcutta. With this brief introduction, may I request Dr. Sunil Lila to take over, sir.
Good evening. Thank you, Chinmay. Good evening. Thank you, Mr. Omkar, and thanks, Alkem, for evening. We are slightly late on the clock, so let's not waste time and straight away go to our cases. So we would have a case, and then we would have a discussion. And so the first case is a 72-year-old male coming to the emergency department complaining of sudden onset chest pain of 1 hour. Pain was typically of cardiac origin. He is a smoker, non-diabetic, history of hypertension. ECG showed extensive inferior MI. The cardiac biomarkers were raised. The blood pressure at the time of emergency reporting was 130/70 with a pulse rate of 70, a regular heart rate. And this was his ECG, which shows acute ST elevation inferior MI, and which has got a lateral extension. So he underwent.
Kindly share the screen of the.
I think sir was sharing, so.
So it's not coming. The screens are not visible.
No,
sir, it is not coming. If you allow, okay, Omkarji can share, sir.
No, just give me a minute again. Just give me a minute. Or like anybody who can share. I don't
can
have
share.
Any problem.
I can.
Yeah,
share.
please,
Omkarji
Mr.
can share from the back end if you allow.
Yes, no problem.
Yeah.
Visible, sir, now?
Yeah. So this 72-year-old male, as we said, that reported to the emergency department of the hospital complaining of sudden onset chest pain of 1 hour, and he is a smoker, non-diabetic, hypertensive. ECG showed extensive inferior MI. Blood pressure was 130/70 and pulse was 70. So patient is ready for intervention. So an angiogram was done. Can we go to the next slide? An angiogram was done. ECG showed hyperacute ST elevation inferior MI with lateral extension, and the patient is ready to go for he agreed to go for a primary PCI and was taken to the lab and had a thrombotic totally occluded RCA, which was a dominant vessel from the proximal part, and he had about 80 to 90% lesion in the circumflex, which of course is non-dominant, but not dominant, but it's a big size vessel, and the LAD was more or less free of significant disease. Now, what should be the plan of treatment of this patient? So we all know that the patient fits in the bill for a primary PCI, and with the medicines at the time of primary PCI, or once the patient comes to the emergency department, apart from the anti-ischemic and statins and some pain relievers in the form of narcotics, which we institute to the patient, and then try to get patient as soon as possible to the cath lab. Of course, we try to load with DAPT. So the options with us are the four: aspirin plus 300 clopidogrel, aspirin was 600 clopidogrel straight away in emergency, aspirin with prasugrel 60 milligram in the emergency, aspirin with ticagrelor. So let's start. So I put in one by one. Let's start with Dr. Talapatra. What would be his choice of treatment and the choice of DAPT in this patient? Dr. Talapatra.
Sir, the patient obviously came with an extensive inferior posterior wall MI, and the patient is ready for intervention. So along with other anti-anginal medication, I will go for DAPT. And my choice of DAPT would be aspirin loading dose along with prasugrel 60 milligram. The reason for choosing prasugrel is the recent Izaria 5 trial, where almost 4,000 odd people were being tested with loading dose of prasugrel and ticagrelor, and it has been shown that the major cardiac side effects, the death rate, the probable and possible stent thrombosis are all are better with prasugrel group than with ticagrelor group. And also regarding the bleeding, it was non-significant bleeding with prasugrel group compared to ticagrelor group. So I would start with load the patient with prasugrel 60 milligram and then maintain with 10 milligram. I will not go for clopidogrel because there was Triton TIMI 38 trial was there, which showed prasugrel was better in perspective of MACE, major cardiac side effect, bleeding, and death rate compared to clopidogrel. So my antiplatelet agent would be prasugrel. Now, how long we would continue the DAPT therapy? That
Dr. Riten will come to that point later. Dr. Supradeep, do you agree with what Dr. Riten says, or you, if you agree, then why? If you add anything, or if you don't agree, then what is your choice?
My choice would be ticagrelor, because I think the patient is 72 years age, and the bleeding risk of prasugrel is little higher than ticagrelor. And the efficacy wise, ticagrelor and prasugrel is almost same. And there is no age over, efficacy wise, there is no age over prasugrel over ticagrelor, and it is almost same. And the bleeding rate overall, the major bleeding is compared to clopidogrel in case of ticagrelor. That's why I would like to use ticagrelor in this patient.
Right. Dr. Anindo, whom do you agree with? Both are one school of thought is that he would go with prasugrel, and the other school of thought is that he would go with ticagrelor, of course, along with aspirin and the other anti-ischemics and statins. So, Dr. Anindo, if you agree, which group you agree with, Dr. Ritendra or Dr. Supradeep?
Anindo sir, can you kindly unmute, sir?
Yes. Yeah, I would go with Supratik's advice. We do the same thing: load the patient with ticagrelor and then take patient to cath lab.
Okay, so you agree with what Dr. Supradeep. So we have Dr. Tapobroto De also. Whom you agree with, Dr. Tapobroto?
Yes, I will also go with ticagrelor because elderly patient, almost around 72 years age, non-diabetic, With prasugrel, bleeding risk is slightly higher, and there is enough evidence of potency of ticagrelol also. So I think I will go with ticagrelol only, along with aspirin.
So we have three in one boat, and Dr. Ritendra is on the other boat. So we should give Dr. Ritendra the chance to stand. So Dr. Ritendra, as we discussed that we would load the patient with DAPT in the emergency. So do you load prasugrel 60 milligram in emergency without seeing an angiogram of the patient? Do you do that?
That is the question. Actually, I would load the patient definitely after seeing the angiogram. To stand my viewpoint, I would say that according to the guideline, 75 years of age and above is the red flag, and below 60 milligram, 60 kg body weight is the red flag.
No,
So,
that's okay. But in emergency, would you load with prasugrel? The
no.
we started
of course, after seeing the angiogram.
So till the patient goes in cath lab, you are not loading with the DAPT instead of the patient having a STEMI.
Actually, there in many emergencies there is a protocol to load with aspirin and clopidogrel, and after taking the patient to the cath lab, after seeing the angiogram, we would load with whatever prasugrel or ticagrelol or whatever DAPT agent we choose. And so as the patient already have done the angiogram, so I thought already the patient would load from the emergency with whatever guideline or whatever protocol they are using, and I would load with prasugrel, as the latest trial of Izaria 5 slightly point the age towards prasugrel. There is a really debate after the Izaria 5 that whether to use ticagrelol or prasugrel. There is the debate will go on and debate will continue. But to my concern, there would be slight age over prasugrel over ticagrelol. So I would load with.
So I have a question.
I have one thing to say.
Yes,
had the patient been diabetic, then it would have been better to load with prasugrel. Then prasugrel has age. But in case of non-diabetic, I don't think. I think prasugrel and ticagrelol are almost same.
So, Dr. you spoke about the Izaria 5 trial, but Izaria 5 was not a trial for ST elevation MI. They had patients with non-STEMI, and they had even complex angioplasties, routine complex angioplasty. So why do you, this is a ST elevation MI. So why do you are like more prone? And I think that the best idea is to load with the ticagrelor even before you see the angiogram, because in ticagrelor loading you don't need to see an angiogram. So what I think the best policy is right now in the emergency, like as you rightly said, that we have a tendency or propensity of the emergency officer that before they call you, they load the patient with aspirin, statin, and P2Y12 inhibitor, which I think is right, because the early you give, the better. But the best policy I feel is ticagrelor 180 milligram, because number one, you don't need to see an angiogram, because in your case, if you are too much prone to prasugrel, if you are too much intended to prasugrel, or like then what happens that you have to either load with clopidogrel and then again load with prasugrel in the cath lab. So I would suggest that it is better that in emergency, the emergency officer should be informed that once a patient of ST elevation MI comes, no matter what policy does he go for a medical therapy or like invasive procedure, unless and until he is going for a thrombolytic therapy, one should hold on with ticagrelor and of course prasugrel. That it is safer to load with ticagrelor rather than prasugrel. Now in this COVID situation, as we were discussing, right now the treatment of choice is not primary PCI. We do give a thrombolytic therapy because we wait for TrueNet. So should you wait? TrueNet would get a report you would get in an hour or two that this patient came with chest pain of 1 hour and acute infeval MI. So would you go for medico-legally with a thrombolytic therapy, or would you still wait for the patient with primary angioplasty? Anybody of four of you can come with your idea. If I am clear with the question that are we going to wait for the patient to get a TrueNet report and just do the primary angioplasty, or because we know that TrueNet report would come in 2 hours, and so why medico-legally the patient has come to you, so should we go ahead with the thrombolytic therapy? So what is your idea? If anybody can highlight in this COVID era, it's very important question for all of us.
No, what we are practicing at AMI is all like we give thrombolytic to patient.
Yes.
Then
So
even if he is coming within 1 or 2 hours, it
okay.
will take more than 2-3 hours. So within 4
Okay.
hours, both are class 1,
Okay.
angioplasty and thrombolytic.
So Dr. Anindo, it was you, isn't it?
Yes, sir.
Yeah. So Dr. Anindo has told that they routinely are in the COVID time thrombolytic. They are giving a thrombolysis to the patient. Now, anybody who wants to criticize or come to Dr. Anindo Sarkar's question that are they right, or if anybody has some other idea?
I particularly feel that if the patient comes within the window of primary PCI, that means within 6 hours, it is better to go for primary PCI always. And in my previous institution in Dishan, we generally used to do primary PCI in this kind of patients, and then the RT-PCR reports come, and then we ship the patient according to that.
The problem is the RT-PCR would take 2 hours. Okay, the window of primary PCR is beyond the time. Like in the early phase, the patient has come of 1 hour of chest pain. Like why not thrombolytic? It would be working because the early thrombolysis also works. Now, if it is beyond 6 hours, if it is beyond 6 hours, then the thrombolytic doesn't work, and we usually take them for a primary. So why not waiting for? See, I want to tell one thing, that if you see the old trials, in fact, statistically, there is no scientific reason, but statistically, it has been seen that patients with inferior wall MI who had been thrombolized in past has got more mortality than patients with anterior wall MI who are thrombolized. So inferior wall MI, for some reasons, thrombolysis doesn't work properly. And this patient has come within 1 hour. And his blood pressures are stable, and he is not in a complication like a complete heart block or a RV infarction, which has not been mentioned. So I agree with Supradeep that I would load the patient with aspirin and a ticagrelor, wait for the TrueNet report, and I would not thrombolize the inferior wall, uncomplicated inferior wall, because we know that statistically, if you see the old trials, the old TIMI trials, that in thrombolytic in inferior wall was more dangerous than doing good. It was doing more harm to the patient, So being an inferior wall MI, I would load this patient with ticagrelor and just wait for the TrueNet report and take him to the lab. And of course, now agreed with Dr. Arindo that we thrombolize the patient. So in that case, I'm sure you would be going, Dr. Arindo, you would be going with clopidogrel loading and aspirin, not ticagrelor?
Yes, sir. If I'm planning to thrombolize, I would load patient with clopidogrel, and then during angioplasty, I have to use loading dose of ticagrelor.
Okay, so that's interesting. Again, he says that straight away he would, the minute he do a thrombolysis, then he gets a TrueNet report, and then he takes the patient as a part of pharmacoinvasive therapy or a no flow situation. Then he takes for a rescue angioplasty, whichever is the plasty. Then he takes the patient to the lab, and then there he loads with ticagrelor. So all agree that he can load a ticagrelor after thrombolytic therapy straight away. Anybody of you can come.
I don't think that after giving clopidogrel and thrombolysis, giving ticagrelor will increase the bleeding risk. Yes. As I have already said that in my institution, I have done 2 primary PCI of COVID suspected patient, came within 2 hours of window period, young patient. So we have taken the RT-PCR sample, and we have straight away loaded with ticagrelor and proceed with primary PCI. So that should be the ideal process. I feel
that's okay. That's one school of thought, and there is no harm if in this COVID era we are thrombolizing the patient and taking for either a rescue or pharmacoinvasive therapy, a part of pharmacoinvasive therapy. So, Dr. Arindo, in your institute, you straight away, in spite of thrombolysis, that you load the patient in the lab again with ticagrelor, that he has received thrombolysis and clopidogrel along with this.
Many a times we are doing that.
Okay. So you had not faced any problem?
Nothing major so far.
Dr. Tapobroto, what is the guideline which says that after how much time of thrombolytic therapy that you can load the patient with ticagrelor if at all you want to switch over from clopidogrel to ticagrelor?
I think it will not be wise to again just after thrombolysis again to load with a different agent. I think if
Within
you are
24
planning,
hours.
because if
24
it
hours.
is in the first 24 hours, we should not switch to a different agent. I think we can directly also load with ticagrelor if you are planning for a pharmacoinvasive strategy anyway.
So you want to say that ticagrelor you can load in the emergency and still give a thrombolytic therapy, knowing that you are thrombolizing the patient, you would load with ticagrelor, isn't it? Once you are loading from 0 hour.
Yes.
Okay. So
If you
what
are
is the
anyway,
harm if you are loading from 0 hour? What is the harm? Dr. Anindo is loading at 4-5 hours. What is the harm? It's all same.
no,
So
we are not switching over to another agent within
okay.
the first 24 hours. That's
Okay. So the idea is the guideline still tells that if for any reason if the patient received a thrombolytic therapy and he is going for a rescue angioplasty or a pharmacoinvasive therapy, you should delay switching over from a clopidogrel to the ticagrelor, even if you want seeing that there is a high thrombus load and you wanted a potent P2Y12 inhibitor that you have to inhibit your intentions up to 24 hours, and then only you can switch over from clopidogrel. It's better to switch over from clopidogrel to ticagrelor. But having said that, the TREAT trial, which was released about 4 years back, showed that patients when were switched from clopidogrel to ticagrelor at a mean time of 11 hours, it was safe. There was no increased bleeding. Okay, and the shifting time or the switching time was from 4 hours to something around 33 hours, and the mean average time was 11 hours. And when they switched over from clopidogrel to ticagrelor, they find that there was no increase in bleeding, but at the same time they did not find that there was any thrombotic benefit to the patient. So I would suggest that if you are loaded the patient with clopidogrel along with thrombolytic therapy, it's better to hold on your instinct till you think it's a prox LAD and a very young patient with a very high thrombus burden that you can switch over. But yes, the TREAT trial did give us an insight that it is not going to be very harmful as we initially thought that we can hold our instinct. We had to hold our instinct to 24 hours. If you feel that the patient is not suitable for a lower P2Y12 and you want a better inhibition of the P2Y12 receptors, or then you can, because the TREAT trial did give us an insight that you can go as early as 4 hours and there is no increase in bleeding. And so that was the TREAT trial which told us. So that's important. Now, coming to the prasugrel and Izaria, I think the Plato trial is a more important trial than the Izaria, because Izaria was not a STEMI trial. The Plato trial included patients with STEMI, and it did show that irrespective of the treatment, like the patient goes on a medical treatment or the patient goes on a primary PCI or any part of any form of treatment, that there was definitely increase in there was definitely benefit with ticagrelor over clopidogrel as far as MACE is concerned, as far as cardiovascular mortality is concerned, as far as all-cause mortality is concerned, and as far as stent thrombosis is concerned, without increase in any increase in fatal or intracranial hemorrhage. There was some increase in bleeding, of course, and there was some increase in bleeding of ticagrelor group over the above the clopidogrel, but it was not the fatal bleeding or bleeding or ICH which were similar in both the groups. Now, coming to the Izaria trial, one important point is Dr. Ritendra. Anybody wants to antagonize Dr. Ritendra, or should I continue? Anybody of you wants to antagonize? It would be good, or otherwise I would continue. So I am telling you, Dr. Ritendra, what it was an open label trial, and it was done in 2 hospitals, one in Italy, a very small number of patients, and one in a particular hospital. And the patient were to buy the medicines. They were not supplied with the medicine. So it was open label, and it was to the discretion of operator that which patient would receive prasugrel, not that they were randomized that one would receive the prasugrel and the other would receive a ticagrelor. So they knew knew that this patient is not a bleeder, so they gave him a prasugrel, and the patient, they knew that's a bleeder, they went with the ticagrelor. And out of that 4,000 patient, as you said, rightly said, that 4,000 patients, 2,000 in each group, nearly 2,000 to 2,100 in each group, 1,200 patients, when they were discharged from the hospital, they were not on their prescribed medicine. So they were in the ticagrelor, about 600-700 patients were not on ticagrelor at the time of discharge, and in the prasugrel, 500 to 600 patients were not on prasugrel on the discharge. Now, if you take those patients who were discharged on the prescribed medicine, there was no difference between ticagrelor and prasugrel. So it's a myth. How do you look into the trial is a myth. So I think the Izaria trial is not a trial which would, yes, of course, it has thrown the prasugrel back in the ring, that it is one of the important medicine, but it is still not the time that we should change our practice from books to practice, or from trial to practice. It's still some time to go before we have other data. And with the Plato trial, with so much of benefit with ticagrelor, if given in ST elevation MI, and 1 year data of Plato, it's a mind-boggling data. So the Izaria trial, or the data with the Izariacs, are still okay. They have opened some insight. They have given, in fact, they have given more questions rather than a solution to the situation that prasugrel is superior. And if you look into this trial, patients who did receive ticagrelor and patients who were destined to receive ticagrelor, and patients who did receive prasugrel who were destined to receive prasugrel at discharge, there were no difference between the two groups. However, there were about 1,200 patients, 600, 700 in the ticagrelor group and 500 in the prasugrel group, who did not receive the medicine at the time of discharge from the hospital. So that's very important. So this trial raised more questions rather than solution to that the question, the answer that which should be there. If anybody wants to come in, or we should switch to the next question. Anybody wants to come? Any comments?
So we can move to the next case also,
yeah.
sir. If you
No, we'll have one important question. So how long to continue? Very important question. So ST elevation MI, how long to continue? Any of the four panelists can come. Any of the four panelists can unmute and come. That how long and what should be the strategy?
Sir, if I are using ticagrelor, then we should see the DAPT score and precise DAPT score to see the bleeding and thrombotic risk, and preferably to continue for 1 year. And if the thrombotic risk is more than the bleeding risk, then more than 1 year. It has been shown in Twilight trial that there is a school of thought that 3 months DAPT and continuing with ticagrelor alone. But I don't think any intervention cardiologists are practicing this right now. Everybody is confident with 1 year of DAPT.
Okay. So anybody who wants to criticize or come in with what Ritendra has told?
I think it is most important is the bleeding risk. If according to precise depth score, the bleeding risk is more, then we can go for short depth. And if the bleeding risk is less, then we have to consider for ischemic risk by a depth score, and then we can consider about ischemic. Then we can consider about extending depth. So basically, it is bleeding risk. Okay. We have to consider it first.
Dr. Anindo or Dr. Tapabroto, if you have anything to say.
Yes, sir. I would like to put patients on DAPT for 1 year, but if his bleeding risk is high, probably I have to curtail it. Otherwise, 1 year.
So after 1 year, what you would do if his bleeding risks are high? You would go with single antiplatelet?
Yes, then switch him to
just aspirin. Okay.
Yes, aspirin.
Dr. Tapabroto, you have anything to clarify?
No, the same. I think we will continue for DAPT at least for 6 months.
So Dr. Talapatra, for your just clarification, the Twilight did not include any STEMI patient. So our patient is a STEMI. So they did not include, STEMI was excluded. So I agree with what Supratit told, that at the time of discharge, you can do a precise depth score. That if you think the patient is a bleeder, yes, you can think of, because the Twilight, although did not include a patient with STEMI, but the Global Leaders trial and the other trials did show that a short duration of DAPT, and then you can switch over from DAPT to only single ticagrelor. That was the global leader trial, that 1 month of DAPT with aspirin and ticagrelor and just ticagrelor alone. It was non-inferior to DAPT, the ticagrelor alone for 2 years. So that is one point. But precise DAPT score has to be done at the time of discharge. Otherwise, we just at 1 year, I think the better idea is at 1 year, you should do only DAPT score, not the precise DAPT score. And at 1 year, if you think that the patient is young, still smoking, diabetic, or he has got more chances of stent thrombosis rather than chances of bleeding, then it is better to switch from the plateau to the Pegasus. What that Pegasus is a 60 milligram BD doses of ticagrelor for another 3 years, along with 75 milligram of aspirin, because the Pegasus has 3 arms. They had seen the 90 milligram doses along with the 60 milligram doses and the aspirin alone group. And the Pegasus told us that if you straight away within 30 days, even if you are discontinued, if the patient comes within 30 days of 1 year, that you start with the Pegasus domain, the Pegasus regimen of 60 milligram BD, there is a MACE benefit. Although there is no cardiovascular death benefit or all-cause mortality benefit, but there is definitely a MACE benefit. And patients, if he is on low on the DAPT score at that time, then you can continue with 3 years beyond of 1 year of 90 BD to 60 milligram BD. So that is the first case. We are running short of time, so we have to stop it here. If anybody wants to talk anything about any of the antithrombotic here, or like add or criticize any of the panelists or me, one is free to do it. Otherwise, we'll move to the next case.
Just to share an important point, that just
Yes,
today, ACC 21, the adaptive trial was published.
Yes,
where
yes.
the question of whether to switch the aspirin dose is being answered. So just to highlight the points.
What was that? What was
if somebody is taking 81 milligram of because they are actually in US there is 81 milligram. So if somebody is taking 81 milligram, they should not switch it to 325 with any cause, for any cause. If somebody is starting the aspirin therapy, it should be 81 milligram. If somebody is tolerating 325 milligram of aspirin, then he would not switch it to 81 milligram. If somebody is tolerating 325, then he would continue 325. These 3 points are the main points of adaptive trial.
Okay, right. Thank you. So we can have the next case. Mr. Onkar, would you share?
Onkarji, next case, please.
Yeah. So the next case is, so we are switching off from ST elevation MI, the antithrombotics, to another domain altogether. And this is a case of a 55-year-old female presented in the OPD with history of palpitation for last 2 days off and on, lasted approximately 15 minutes. And she had a similar episode sometime back, 3 months back. Past medical history, she is hypertensive on telmisartan 40 milligram, but not regularly taking the medications. She is non-diabetic, no history of cardiovascular disease, no history of any major surgeries. She comes from an upper middle class vegetarian diet family. No antiplatelet or anticoagulation she is receiving. Her blood hemoglobin and CBC was normal. The hepatic and the renal functions were normal. The thyroid function was normal. ECG was normal, and sinus rhythm. Echo was normal. So next slide, Onkarji. So the clinical examination was blood pressure 122/84, pulse was 78 regular, and so nothing was found, and so she was advised the Holter monitoring, 24 hours monitoring, and the Holter monitoring did show that there was short runs of AF, and the longest run of AF was of approximately 10 minutes during the daytime. Next slide. Yeah. So the points to be considered now: should we start an oral anticoagulant in this patient? If yes, which oral anticoagulant? Would you go with Novax, or would you go with vitamin K antagonist, or would you not start anticoagulants, or would you just give a single antiplatelet agent like aspirin to her? And if you start any of this treatment, how long should be this treatment continued? And do we need to consider the following points: the age of the patient, the cost of the therapy, the drug diet interaction, compliance with the drug, ability to do regular monitoring, cardiovascular risk, bleeding versus ischemic risks? So any of the panelists can come. So do she require or do she fits in that she should be given an anticoagulant? And if yes, then which one, the NOAC or a BK?
It's a non-valvular AF.
Yes.
So we will calculate the CHADVAS2 score.
Uh-huh.
And if it is
so the data are in front of you. So what is the CHADVAS2 score for this lady?
Please show the previous slide.
Can we go to the back, the one slide back, Mr. Onkar? No, the other previous slide. Yeah. So she is hypertensive.
Hypertension.
And no other history of diabetes or ischemic heart disease or anything. All other reports. Yeah. Huh?
So female patient, hypertensive.
Mm-hmm.
So it will be a CHADVAS2 score of 2.
Yes.
So a CHADVAS2 score of 2 in female is a class 2A indication, and 3 or more is a class 1 indication for starting anticoagulants.
Yeah.
And I think since it's a non-valvular AF, now NOACs are also indicated as a class 1 indication unless there is a issue of the cost and affordability.
Right. So anybody, it was Dr. Anindo, I'm sure. So anybody criticizes Dr. Anindo? That
Sir,
she really
it was Dr. Tapobroto, sir.
Oh, right. I'm so sorry, Tapobroto, because I can't see who's talking. So anybody criticizing Dr. Tapobroto? He is the least talking among 5 of us, you know. So I'm sure one should criticize him, you know, because he's not talking. Anybody? So all agree that she requires anticoagulant?
Yes,
Anybody?
sir. The patient is a female patient.
Yes.
And having the history of hypertension, to correctly the CHADVAS score is 2.
Yes.
And it puts her to the class 2A indication of starting and NOAC of oral anticoagulant. So we would go, if the cost permits, then we will go for novel oral anticoagulants.
Okay. So I congratulate Dr. Tapobroto. He rightly said he calculated CHADVAS score perfect, that it is a CHADVAS score of 2. And once the CHADVAS score of 2 in female is a 2A indication, it's not a class 1A, class 1 indication. In males, it is a 2 is a class 1 indication. In female, it is 3 to get a class 1 indication. So she is a class 2A indication to receive a oral anticoagulant. And of course, if she gets an oral anticoagulant in this modern era, we should go with, because she had, she requires oral anticoagulant, so we should go with the NOAC. And as Dr. Tapobroto rightly told, the ACC, AHA, the ESC, everybody tells that if the patient is eligible to receive a NOAC or a VKA, it is NOAC which is preferable to VKA, which is a class 1 indication, level of evidence C, because they are less bleeders and if not more, equally potent. Now, so 2 question comes. So which NOAC would you choose? And are all NOAC equipotent? Anybody? Anybody? What is your choice? Look, okay, let's put it that way. Supradeep, what is your choice of NOAC here?
So in this case, we can choose Apixaban or Dabigatran because renal function is similar. But however, Apixaban is more potent. Apixaban has some edge over Dabigatran for my, at least to me. GI bleed is less.
Yes.
Number 1, the trials are superior. Apixaban are superior compared to VKs, and number 2, bleeding risk are really low with Apixaban.
So your first choice would be Apixaban. And so what is the dose of Apixaban you will choose?
5 BD, 5 mg BD.
Okay. So anybody want to come in and answer, like have a different choice, or they all agree with Apixaban?
I would think, sir, both Apixaban and Dabigatran both have a good renal safety profile.
Okay.
And both can be used.
Okay.
If somebody can use Apixaban, then 5 mg BD. If somebody can use Dabigatran, then 150 mg BD.
Okay. So what is the renal safety profile, dear? What that mean, Dr. Ritendra? Like do NOAC causes
yeah.
decrease in renal
No,
profile?
actually, in creatinine clearance less than 30, it is contraindicated.
No,
But
we have said that renal function is normal. So why
Yeah.
you all are against rivaroxaban? I say that rivaroxaban is the drug of choice. Anybody can criticize me. Because two speakers has come and both had a choice, either apixaban or dabigatran. But I said rivaroxaban. So anybody can come and criticize me. Why not rivaroxaban?
Anindo sir, kindly unmute, sir.
Anindo, please come in.
Rivaroxaban has the benefit that patient has to take it once daily.
Yeah, fantastic.
Yes.
He is telling that rivaroxaban has a benefit that he or she has to take one tablet, and
but if we
so that's
think
important.
of bleeding, then I think apixaban is first choice.
So
GI bleeding is more with rivaroxaban.
If you think of bleeding, then
But I think overall the fatal bleeding and the intracranial bleeding is also quite less with rivaroxaban.
So any choices? Any more choices? So all three fits in. So what I would say, when the renal function is normal, that any of the doses has to, any of the medications like the three which is on board right now, dabigatran, rivaroxaban and apixaban, all three are same because all are non-inferior to VKA. So one thing we all agree that VKA is not the choice because VKA is only two choices today. It's a moderate severe mitral stenosis or a prosthetic valve in the heart are the two causes with atrial fibrillation that you cannot use a NOAC. Otherwise, NOAC replaces VKA, and the ACC guideline also tells that if the patient is eligible for both, it is safer to go with NOAC as a class 1 indication that you should switch over from VKA to NOAC. Now, we all know those small things that NOAC doesn't require, like you don't require blood test to see the NOAC label. There are less drug and drug-food interaction with NOAC, and those appear safer. But now coming, because the hepatic and renal functions are normal, so all three are eligible. So apixaban, rivaroxaban, and dabigatran, all three are eligible. Now coming to the cost, because someone, two of the speakers wanted that the cost is an issue in India. I agree with you. We are in a poor country. So two of the medicines are off patent and generic. The dabigatran, which is off patent for last 3 years, and the rivaroxaban has become off patent in last 6 months. So, and why shouldn't you criticize Dr. Arindo? He said that rivaroxaban is superior because you have to take a once a day dose. Why not? Why? I think that he is right because both are off patent, both are generic brands. So cost is not an issue. Why? I still would not go with rivaroxaban, but any of you criticize Dr. Arindo that he says that rivaroxaban is a better medicine. So if no one comes, I'll tell you 3 points, very important points to be remembered. It is just not only that you need to write a NOAC. It is for all the people who are there attending the conference, one has to know. It is the right doses of NOAC, which is very, very important. And it is the 150 milligram twice a day of dabigatran. It is not only non-inferior to the VKA as with the other NOACs, it is superior to the VKA in preventing ischemic stroke, both stroke and systemic embolism, and with no increase in major bleed. Yes, of course, it has got some increase in bleeding vis-a-vis the 110 milligram dabigatran dose, but it is not the ICH or not the hemorrhagic stroke which has any significantly increased if you give 150 milligram of BD doses of dabigatran. And once the renal function is normal, you should write a medicine that is in a proper dose, which is superior. Why should I write a medicine which is non-inferior? I would write a medicine because all three are eligible, and the only medicine which is eligible to get a superiority, it is the 150 milligram BD dose. If someone have told 110 milligram if the patient is eligible for 110, yes, I would have gone with rivaroxaban because in that case it would have scored before that 110 milligram dabigatran because all the medicines are non-inferior and rivaroxaban scores over 110 milligram dabigatran that it is to be given once a day. So that is it. But here the lady is should be given a 150 milligram BD dose of dabigatran rather than giving 110 dabigatran or a rivaroxaban or a apixaban. Now, another point of importance is very important is if you see the three important trials, the Rely trial, the Rocket trial, and the Aristotle trial, only the Rely trial was the only trial where there was 50% of the patients of both 150 milligram and 110 milligram included in the patient trial. So we have data with proper 110 milligram and 150 milligram. The Rocket AF trial with the rivaroxaban, which included about 6,000 patients, only about 1,400 patients did receive the reduced dose of rivaroxaban. And in apixaban trial, out of 8,700 patients who received apixaban, only 400 received 2.5 milligram doses of apixaban. So apixaban, just telling that is superior as far as bleeding is concerned, no, it is not. It is the dabigatran which is non-inferior as far as bleeding is concerned and superior as far as prevention of stroke and systemic embolisms are concerned. And how do you, how is the bleeding important once you are not tried? And bleeding is not the propensity of a medicine. The propensity of medicine is to prevent stroke. The medicine is given to prevent stroke. You are not supposed to be, see, it is a fight which is going to continue between the physician and the patient. If you ask a patient that, would you mind bleeding or would you mind a vegetative life after a stroke, she would always say that I don't want a stroke, and that is why you are giving me a medicine. But as a physician, we are always concerned that the patient may bleed, and that is what is very dangerous to do. So just not writing a NOAC is important. Writing a NOAC in a right dose is very important. Otherwise, you are going to miss the bus. And it is the 150 milligram dabigatran twice daily, which has been well established in the Rocket Rely trial, and it has been well studied in the Rely trial, which no other trial has shown, and they have studied. And it is found to be not only non-inferior, it is superior as far as the primary endpoint of stroke and systemic embolisms are concerned, the ischemic strokes are concerned, the hemorrhagic strokes are concerned, the ischemic, the intracranial hemorrhage are concerned, and any cause on all-cause mortality. So everything is superior with 150 milligram of BD doses of dabigatran, and at the same time, it is a generic brand, so cost is not an important function. Yes. If the patient has to be taken a reduced dose of dabigatran, well, all three comes in a similar, because all three are non-inferior. Now, another important point is very important. One should note that if you see, if you see the real world data vis-a-vis the phase 3 trials, like the 3 trials I'm talking, the real world data is very, very, very disturbing. Now, what happens in real world data, and you all would agree with me that in most invariably, it is the apixaban the physician tries to write in a 2.5 milligram BD doses. So it is always underdosed. And that underdosing is as to the tune of 37% in with apixaban, and about it's about 30% with rivaroxaban, and it is only 5% with dabigatran. So dabigatran people are giving in proper doses, whereas apixaban we have a tendency to underdose it. And once you underdose, the chances of stroke and systemic embolism increases by 6 times. And this is only mainly driven if there was a registry, Danish registry, which included only the low dose, the patients who were receiving the low dose of dabigatran 110 BD, the rivaroxaban 15 milligram and apixaban 2.5 milligram. The Danish registry, what did it show? That there was an increase in systemic embolism and stroke. And this was only driven primarily by the low dose apixaban, not by the low dose 110 milligram dabigatran, and neither by the 15 milligram of rivaroxaban. That is one point. And what was the reason of underdosing the apixaban? We invariably underdose because we are scared of the bleeding, and there was no bleeding advantage once you underdose with a 2.5 milligram, because if you underdose all the medicines, bleeding is going to come down. So bleeding is not the propensity of the medicine, and you should not be scared of the bleeding. You should write in a proper doses. That's the take-home message. I'm again talking very loudly and very clear that the take-home message is just not writing a NOAC, but writing in a proper dose. So 3 things you have to keep in mind: the age of the patient, the creatinine clearance of the patient is very important, and once you do it, do a Hasbro score, Chadwa score, you are done because you are writing a medicine, and then choose your medicine and try to choose a medicine which is in proper doses. That's very, very important, to choose the medicine in proper doses to become a superior medicine, just rather than to become a non-inferior medicine. And it is the dabigatran 110 milligram, 150 milligram twice daily, if given in proper doses, if the patient is eligible, that is the medicine which is superior to the VKA, and the rest 2 medicines doesn't fit in the bill. So that is important. Of course, if nobody comes, I would just use a phrase that the ships in the harbor is more safer than the ship which is sailing, but the ships are not meant to be kept in the harbor. So you have to come out and use the medicine. That's a very important medicine. And if you ask the patient, I'm sure all your patient would say that I don't want a stroke. I don't know when I would bleed, and it is just like assumption that I may bleed. So I'll bleed, I would see. The day I would bleed, I would see. And when did we found that the patient died of bleeding? Any of the four panelists can come and please highlight if you have any patient who bleeded with a NOAC and died. Please let me know. Even if the GI bleeding, which is the most worrisome with dabigatran and to some extent rivaroxaban, and people talk that apixaban is superior. Why GI bleeding? The GI bleeding stops once you stop the medicine. In fact, the rivaroxaban COMPASS trial, not the COMPASS trial, the other trial, there was a Japanese study with rivaroxaban, and they said that if the patient bleeds on rivaroxaban, these are the patient GI bleed from the rivaroxaban. 10% to 15% of this patient has a hidden malignancy. So this patient, if you now, they would have diagnosed malignancy 2 years later, which you would have diagnosed today. So please don't hesitate in writing a NOAC first, and then NOAC also in a proper doses. This is my take home message. And of course, as I said, the ship is more safer in the harbor rather than sailing, but they are not meant for that. The medicine is an anticoagulant, so it is to prevent stroke and systemic embolism. And bleeding is a propensity. As the Chadwick score increases, the chances of bleeding would increase. So you are not to be scared of bleeding. And GI bleeding is not a major, yes, there are more incidences of GI bleeding with dabigatran and rivaroxaban compared to apixaban, but they are not harmful, they are not life-threatening. There is no increase in ICH, there is no increase in fatal bleedings, you know. So this is very important, and this is what is my take-home message, that write a medicine. Yes, of course, make a habit of writing medicine. Write the medicine in proper doses so that it becomes a superior medicine, and don't be hesitant in thinking that bleeding, I know that holds the clinician to write a full dose and proper doses of this NOAC, which is very, very important. This is my like concluding remark for the second case. If any of the panelists can come, otherwise we end the session and I hand it back to Chinmay and Omkarji.
Sir, I have one thing to comment.
Yes, yes.
I think dabigatran 150 mg is superior, as well as apixaban 5 mg BD in Aristotle trial. I think so. These two drugs are superior, but with dabigatran, I have one issue. I have seen few GI bleedings, and at least one intracranial bleed I have seen. Fortunately, there is Praxbind and that antidote is available for dabigatran. So that's why there is no mortality. But particularly with apixaban, the bleeding risk is less. The only issue is apixaban is cost, excessive cost for apixaban.
I agree, Supradeep. The GI bleeding is less with apixaban. So once your patient bleeds on dabigatran with the GI bleed, once the patient comes with the GI bleed, yes, of course, then I have to change the dabigatran, and then my choice would be apixaban. But till you bleed from the GI tract, I would not hesitate in writing a hold on the benefits of dabigatran over apixaban, because invariably the real world data you would find, you keep your hand on your heart and find out that how many times do you write a proper dose of apixaban 5 milligram BD. Invariably the clinician do write a underdosing of apixaban. That's point number one. The cost is point number two. And the third is the apixaban just reached the statistical significance as far as the stroke and the systemic embolism was concerned. But if you see the ischemic stroke, it was not superior. The apixaban was not superior. If you just see the ischemic stroke, and it was not superior as far as bleedings were concerned, as far as intracranial hemorrhage was concerned or fetal bleedings were concerned. Yes, of course, GI bleedings were less with apixaban vis-a-vis in both the doses vis-a-vis the dabigatran, but let your patient have a GI bleed first, then only you should. And this is a young patient, she's a 55 year, we are not even a class 1 indication. And as I told, as the Chadwick score increased, the bleeding score would also increase. So why hesitant? And as you said that Praxbind is available, which gives you some sort of confidence at the back of the mind that there is an antidote available if there is some bleeding which could require an antidote. So that's my point to you, Supradeep.
Omkarji, can we take any questions? If
there are questions, I'm ready to take them, and any of the panelists can answer.
Yeah, there is one question, sir. If the patient is on NOAC and is about to go a PCI, after a PCI, is it probable for like DAPT plus anticoagulant? And if yes, then what's the duration of therapy in that case?
Anybody of you can answer. So, the question here is, if nobody is answering, I'm telling that it's a triple drug. So the patient is already on a NOAC and he is undergoing a PCI. So now, how long we should continue with triple drug, and then how long, like, and if not, when should we stop and when should? So these are very, very like debatable. The Augustus trial with the apixaban, which is the latest of the three trials with the three medications, had shown that once the patient gets discharged from the hospital or from the first visit, you can take off aspirin and just continue with apixaban and clopidogrel. Well, of course, if the patient had the ACS, I would like to have all three on board for 1 month, and the choice would be rivaroxaban. In my choice would be rivaroxaban 15 milligram with clopidogrel 75 milligram and aspirin 75 milligram. And if it is an ACS situation, I would continue it for about a month, all these three. And after 1 month, I would switch off we would take off the aspirin and just continue with the clopidogrel and rivaroxaban for a year. And after 1 year, only the NOAC is going to do. Now, this is for ACS situation. If it is a non-ACS situation, after 1 week or 2 weeks maximum of the triple therapy, I would like to withdraw the aspirin because I'm scared of the bleeding, and NOAC is important to be continued because the patient had some reasons of taking a NOAC beforehand the PCI. So this is my take. And the NOAC of choice is 10 milligram, 15 milligram rivaroxaban. Of course, if it is an AC situation, you can use either clopidogrel or even ticagrelor, which is not shown to have increased too much of bleeding. Around 9% of the patients in the Augustus trial and in the trial, the Pioneer PCI trial with the rivaroxaban had about 9 to 10% of patients were on ticagrelor. So both are good, and this is my take that if the patient is ACS, we would give it for 1 month. If it is not ACS, we can withdraw after 7 days of triple therapy. If anybody wants to come in, please come in and give their choices if they have any.
There's one more questions are coming up.
Yeah.
This is somewhat different from the topic, like we're
Yes.
discussing. Is there any role of like ticagrelor in managing a COVID patient? Because patients are given aspirin upon discharge. Can they be given ticagrelor? So this is an odd question coming up. So
I would ask any of the panelists to answer, because of late I am also hearing that people are getting aspirin on discharge, which I am not aware of it, and I don't know. But I only know that if the patient is a moderate to high risk and he is hospitalized and is going home, and the D-dimer high, yes, 30 to 40 days of small doses of the underdosing to preventable doses of the NOACs, like 110 BD or 110 2 tablets at a time of dabigatran, or 10 milligram of rivaroxaban or 2.5 BD of apixaban can be given. I'm not aware of the aspirin. So any of the panelists can come and answer if they are aware of this.
There is no guideline of aspirin at present.
Okay. And so any role of ticagrelor?
There is no question of ticagrelor.
No. So, Omkarji, so we are not aware. So all the panelists and I all agree that we are not aware that ticagrelor is directly of any help in COVID situation. Of course, in moderate and severe COVID recovering patients, any of the NOACs can be given. And patient who had COVID and atrial fibrillation, the best NOAC to be given is a dabigatran, because dabigatran has got the least hepatotoxic. And there is a recent trial, the Enable, which shows that there are multiple or polypharmacy in a patient who is discharged from COVID infection. So the safest being the dabigatran, which is not being metabolized by the P12, P2 450. So that's the best of all the patient. If a patient is to receive the full doses of dabigatran or a NOAC for that matter, he has atrial fibrillation and COVID. However, for prevention in like post-discharge, at the time of discharge, it is 110 milligram of dabigatran once daily, 2 tablets, or 10 milligram of rivaroxaban, or 2.5 milligram of apixaban.
Yeah, fine, sir. The questions are, I think, over. So over to
Okay.
Chinmay, sir.
So any of the panelists, if they come in with their comment, the final comment, otherwise I'll hand over to Mr. Chinmay. In fact, I enjoyed the session. I hope everybody enjoyed as well as I enjoyed. And Mr. Chinmay and Mr. Ankar would tell us better that how did they enjoy and what was the session all about. Thank you.
It went very smoothly, sir, for my side feedback, if you ask me. It was very wonderfully moderated by you and great discussion by all the respected panelists, sir. Great, sir. Over to Chinmay, sir. Thank you, sir.
Sir, we take this opportunity to thank Dr. Sunilila sir for moderating the debate in the best possible way and ensuring clinically relevant messages goes to all the doctors who are attending this debate. I also take this opportunity to thank Dr. Supratim Kundu sir, Dr. Tapobroto De sir, Dr. R.N. Tolapatro sir, and Dr. Anindo Sarkar sir for sharing your clinical experiences. As you know, we would like to thank all the doctors also who are attending this debate. And we at Alchem Laboratories will continue to be with the medical fraternities, be with the doctors and support the patient by making our product Tikavic and Deviclot and TSAT available in and around the city. Thank you so much for participating.
Before Chinmay, just 1 second. All the panelists are here. They're scared of. I just forgot to tell one thing. The GI bleed of dabigatran is not the upper GI bleed. It is the GI bleed because of the dabigatran is a tartrate salt, and the tablet goes in the small intestine that causes local irritation and causes GI bleed. So that's a nuisance bleed. It's just a iatrogenic bleed of dabigatran. So one should not be very scared. Yes, it is the rivaroxaban which causes upper GI bleed. So the GI bleed of rivaroxaban differs from the GI bleed of dabigatran. It is the dabigatran, it's a salt which is in the tartrate salt. So that tartrate salt tablet goes in the small intestine, and if there are any ulcers or anything in the small or a polyp, that may erode and that gives a local bleeding. So please take my word, the bleeding of dabigatran is more with the GI bleedings are more, but they are not very serious. I'm sorry, even after the vote of thank, I added this one line, but that's very important to be known. The GI bleed of dabigatran is because of its salt, not because of the medicine per se.
Thank you so much for your concluding comments, sir. I personally thank you all for participating in this antithrombotic debate. And in future, we would like to conduct such academic initiative on more frequent basis. Thank you so much.
Thank you.
Thank you.
Stay safe. Stay safe, everybody. The younger generations, they are doing primary on just phone calls. Bad, Ritendra.
Thank you, sir.
Thank you, sir.
Thank you. Thank you, everybody. Thank you. Thank you.